And you know, in this area, so much of healthcare just sort of happens. You know, it's this layering effect where you do something and then you change it and you do it again and you change it. This is an area where there's a real sense of planning, and it's been going on for a long time. I was with then Congressman John Kasich in Congress in 1996, where there was a bill to do administrative simplification. You know, and we thought in a couple of years, healthcare information would all be moving electronically. You know, and here we are, these 18 years later, and we're still working on it. But there's something different now where it really feels like there's traction. There are the tools in place, there's an imperative to change, there's an understanding of what can work, and what usually works is taking a system that pulls apart and putting the pieces back together. And technology is really the tool to do that. So some of what I wanted to share is just our script here in Ohio. You know, what is the plan? There's a federal framework. What is the state strategy to tie into that federal framework? To then provide support to what are really regional healthcare markets. You know, we're all in a different place in this. For our region, for what we do locally, where are we in this? I wanted to knit some of that together. The starting point, and this is really the imperative, the system is not working as well as it could. You know, we've known this for a while. In Ohio, we spend more per person on health care than residents in all the 13 states. So we spend a lot. But look at that last point there. 41 states have a healthier workforce than Ohio. So we're spending a lot, but the outcomes aren't following. What is it about who we are, you know, what we do in our healthcare system that is creating this disconnect? You know, we have examples we can look at, and a lot of what we've been trying to do at the state level is focus in on hot spots in the system. You know, healthcare works pretty well for most of us most of the time. But within the system, there are these places where things go wrong. If we can find those and focus on that, that I think is really the opportunity to make quick, meaningful change. So here's an example. In Ohio, we use the emergency department 29% more frequently than on average elsewhere in the country. What's going on with that? Is it a lack of access to primary care? Is it coordination prior to that leads to complications that then necessitate a hospital visit? What is it that we can address there? It's a hot spot we can look at. Unfortunately, that number is now wrong. It's not 29%. The Dayton Daily News reported last week, it's actually 34%. We use the emergency department 34% more than the average. Here's another example. You're going to meet Tracy Plouk here in a minute. She's the director of Ohio's Department of Mental Health. We've really put a lot of focus on behavioral health because of this hotspot. What you're looking at here are Medicaid enrollees. In red, Medicaid enrollees with severe mental illness. In blue, Medicaid enrollees without serious mental illness. You're twice as likely to have an avoidable hospitalization if you have a mental illness for diabetes, COPD, for asthma. So again, there's a clue here. This hotspot says something about if we're treating behavioral health over here and physical health conditions over here, something's going wrong there. When a person with mental health needs shows up in the emergency department, are they getting an automatic immediate referral to behavioral health services? Maybe or maybe not. Or if they're being served in the behavioral health system, are we sure they're getting their health care needs met? So these are clues to focus our attention like this. What you're looking at here on the left are people. 5% of the population accounts for more than half of all healthcare spending. Now normally healthcare reform zeroes in on everybody, right? For Medicaid, we're going to increase copays. We're going to eliminate optional services. Those are changes that affect care for everybody. But most people are spending very little. And then we tend to shy away from things, those few who are very expensive. Seniors, people with disabilities. But those are the folks for whom the system is most failing them if there isn't coordination across the different settings of care. So in this administration, we've really tried to zero in on who are those few to improve care. And often, if you give somebody what they want, I'd rather stay at home, not go into a nursing home, well, that's also less expensive. So there's this magical policy fact here where what people want in healthcare is often less expensive than the alternative. So how can we find those? Some of those folks in that small group of being very expensive, they're just expensive. You know, they have a condition that they're just going to be expensive. And we're not talking about withholding something from them if they need it. But for some of the folks in that small group, they're expensive because the system itself failed them. They could have gotten preventive care. They didn't have to have that drug interaction that then put them in the hospital for 3 weeks. When the system fails, those are the things we need to focus on. A few people are expensive, often because of the fragmented system. So how do we get from the left-hand side of this chart, which is where much of healthcare occurs, multiple separate providers, provider-centered care, lack of comparison data, over to the right, coordination, accountable medical home, patient-centered care. Well, this now tracks to the federal framework for HIT, right? Because one of the most powerful tools to knit together coordinated care is electronic health information, our ability to share that. So this is to what purpose? It's a tool to what purpose? To coordinate. I want to briefly mention how we're focusing at the state level. To what purpose? This is kind of our script for health system change. What you see here are 3 charges the governor gave my office, which is a fantastic job. It basically acknowledges that the state of Ohio itself is fragmented in its organization. We have a Department of Medicaid, aging, alcohol and drug addiction, mental health, systems that are sometimes going like this. The Office of Health Transformation puts those together to plan and to budget. And this is our plan. So our first step was to look at modernizing Medicaid. And we've been working on this. We were working on this a year and a half before the governor was elected. So when he was elected, we were ready to go with a budget that gave us the authority to then implement some things this year. So in the news recently, you've been seeing some of these things rolling out. Integrated Medicare, Medicaid benefits, streamlining home and community services, rebalancing long-term care, getting money out of nursing homes into home and community-based settings, creating health homes for people with serious mental illness, which Tracy Plouk is going to talk about. So these are delivery system changes, the key to the success of which are going to be having information tools. We're now moving on to a second layer of activity, streamlining health and human services. And this is where we're bringing a real focus to accelerating electronic health information. Think of this as systems. If you're in a hospital, if you're in a physician practice, if you're in a university like this one, where I used to work, it's nice to be back in OSU. You know, these are the systems. For Ohio, we have eligibility systems. We have 150 categories of eligibility just to get access to the Medicaid program. We're trying to take that down to 2 categories. How do we simplify these systems in a way that then improve access to health coverage? So simplifying eligibility, sharing data across our systems, integrating claims payment systems, accelerating electronic health information exchange. This is where we're trying to get our house in order to be able to be more efficient and do these things better. On the HIE piece, and some of this chart flows from the meeting we had 5 weeks ago or so with the national coordinator. These are just some of the things we're thinking about from the state of Ohio. We want to elevate HIE to the highest level in state government for focus, which is the Office of Health Transformation. And we want to establish our HIE coordination out of that office. We want to build on the success of EMR adoption. It is incredible where Ohio stands in terms of EMR adoption. We want to build on that momentum, not relax, but push it, accelerate that even more. Clarify Ohio privacy law. This is a great example of where the proper role really lies at the state level. States control privacy law. In Ohio, we have privacy laws that exceed the federal privacy law. That variation, that difference, can lead to difficulty in interpretation that causes people to say, well, wait a second, I'm not sure I can share that with you. And that is a killer to electronic health information exchange. If you're not sure you can share, then it can't move through an electronic system. So we have a bill in the legislature right now that would say for electronic AHIE, the federal standard applies, period. And we're hoping that's enacted within the next week or two. Linking meaningful use to practice transformation, exactly what Judy was talking about. Extending meaningful use to other providers, hospitals, primary care. What about behavioral health care providers, nursing homes? How do we eventually think of this as a completely connected system? Making public health a trading partner, getting away from having to have a separate registry for everything. It should just be gleaned as information is shared. And then for us, creating a core informatics team to make sense of, there's so much information. How do you use it? How do you really make decisions? So we need more capacity ourselves. Why do all this? Well, it's this final flow here, improving overall health system performance. This is what it's really about, right? How do we standardize performance measurement? What does performance mean? How do we look at that? How do we publicly report information about quality and price? How do we learn the best ways to do this? Encouraging patient-centered medical homes. You're going to hear from Dr. Ted Winslow, Ohio's Director of Public Health, about our patient-centered medical home initiative. Comprehensive primary care initiative. Southwest Ohio just got this award from the federal government to have a multi-payer focus on supporting patient-centered medical homes. How do we learn from what they're doing statewide? Because really where we need to get is reforming the payment system. We get what we pay for. We pay for units, so what do we get? A bunch of separated, fragmented units. How do you pay for value? How do you start organizing things together in a way that you're looking at the outcome for the individual, and then you're holding the system accountable for that, and you're paying accordingly? Very hard to do. Patient-centered medical home is a step. Accountable care organizations are the goal, but we are far from that. So how do we take what you're doing here today, these tools like electronic health information, and get there as quickly as we can? So I appreciate your time. Like I say, this is an area that makes some sense. There's a federal framework. There's a state strategy. Now, what do you do regionally to kind of act on this, to take the next step, whatever's most appropriate for what you do? So thank you. There's more information about this on the website. I am speeding through this so we can get the detail from Tracy and Ted, but I do appreciate the time you're taking today, and good luck with the rest of the program.